Good evening, everyone, and welcome to our virtual event on COVID-19 vaccination. I'm Sam Dalton. I'm the Events and Membership Officer for the Trust, and I've just a couple of housekeeping points before we start. So we have collated all the questions sent in advance, but to ask a question not already submitted, then click on the question mark chat icon at the top right of your screen on the row of icons, as you can see highlighted here. If you click on that icon, the Q&A chat channel opens. You can see in the highlighted area at the bottom of the chat channel, click here to ask a question. Type your question in the box and tick the remain anonymous box if you do not want your name to be added to the question. Our moderators will go through the questions and forward them to the panel. The most popular questions will be made visible by the moderators. We will have some time after all speakers have presented for questions. We hope all goes well technically tonight, but please bear with us if there are any technical hiccups during the event. I'll now pass you over to Peter Hollins, Chair of the Trust Board and our Chair for tonight's session.
Sam, thanks very much indeed, and I'd like to welcome everybody. I've always really enjoyed our members' evenings, the evenings that we've had from time to time for members of the Trust, where we've turned out scientists or clinicians, sometimes members of management, really to talk to the membership about the things in which they're interested. And it was a shame for a long period, whilst COVID was at its height, we were really unable to do anything for quite obvious reasons. But I'm now absolutely delighted that we're able to restart our members' evenings, albeit virtually. And so it's, for me personally, it's a very exciting evening. Obviously, there's been a huge amount in the media about COVID vaccines over the course of the last year or so. Some of it's been good, some of it's been bad, and some of it's been indifferent. But the terrific thing about this evening is that our membership has got the opportunity to hear from a group of people who really know what they're talking about, and from whom you can get some real truths. We've got a bit over an hour, and we've got several speakers, so we're going to go on fairly promptly, with the principal question session being at the end. So we're going to start with Professor Saul Faust, who, like many of you, I've got used to hearing coming on through my radio quite frequently. Saul has been director of the National Institute of Health Research and Southampton Clinical Research Facility for the last 15 years. He's a professor of pediatric immunology and infectious diseases within medicine at the University of Southampton. So, Saul, over to you.
Thank you, Peter. Can you hear me okay?
I can.
Great. Well, then I will start. So thanks very much for inviting me, and I'm going to give you a brief rattle through the COVID vaccine research, some of the results, and what we still need to do and find out. So just a reminder, you've all seen the coronavirus on TV with its spike protein. When that gets into the body, the cells of the immune system work together to do two things. They produce antibodies that provide direct protection, but they also make the cells that remember the coronavirus and then respond to future infection, even when those antibody levels have fallen over time since the initial injection. And that's the B and T cells that you hear about again in the media. And we use booster vaccines to increase the antibody and help the body remember how to respond quickly. So the main course of vaccine is the prime boost, one dose, then the second. But we also need to know about how to use boosters in the future. So when we're developing new vaccines, we need to know that they're safe. We need to know whether they make an immune response, whether they can protect against infection, how long will that protection last, and whether to combine different technologies in sequence, so one vaccine and then a different type of vaccine. And as I've just said, will boosters be needed, and if so, how often? And obviously this takes some time. We've had this amazing research program since April last year. It's just over a year since we immunized our first participant in the Oxford vaccine trial here in Southampton. But a lot of these questions do take a bit more time to get the answers, as I'm going to explain to you. So the Vaccine Task Force, part of the BEIS, Department of Business, the Vaccine Task Force has ordered and purchased a number of vaccines of different technologies for us to be able to use in the UK, including the AstraZeneca and Pfizer vaccines that are already being used, but also other vaccines that you can see on the screen that are coming online. So we're using Moderna now, but Novavax we're expecting to hear the regulatory opinion on from the MHRA very soon. Valneva, the study starting in Southampton next week. Janssen, we are doing the 2-dose study here in Southampton, and we'll come back to that. So to get these studies done, we quickly realized it couldn't just be Oxford and Southampton. We were the first centre outside Oxford to take part. We had to develop this national network for COVID vaccine trial delivery. All 15 regions of England, plus Scotland, Wales and Northern Ireland. We've set up research coordination and governance and had to deal with the staff training, logistics and the 24-hour on call for people who had symptoms, because when you're doing a vaccine trial, you need to, that's the point, is to find people who have COVID and who don't. And for the Oxford study, we were actively monitoring people for infection, even without symptoms. And that was the only study that did that. So this was a huge piece of work, and we couldn't have done that in Southampton without this being an integral part of the research work of the hospital. So the vaccines that have been deployed and the data you see in the news is quite complicated to understand. The most important thing is all the vaccines prevent hospitalization and death. And the AstraZeneca Oxford vaccine, because we were monitoring for infection, like I just explained to you, was the only vaccine to demonstrate effect on asymptomatic carriage, so COVID in people without symptoms, in the trials. But we're just starting to see real-world data for both the AstraZeneca Oxford vaccine and Pfizer about transmission, and I'll tell you a bit about that a bit later, because it was in the public domain just today, which is really exciting. The other thing you need to know is you can't compare the trial data directly. All the trials use slightly different definitions of COVID-19 infection. So you might have seen the 95% for Moderna and Pfizer, and wasn't that brilliant? But actually, the AstraZeneca and Janssen trials showed lower headline immunity because we were including in the trials cases with milder symptoms. So you can't compare apples with oranges. The important thing, as I said a minute ago, is that all the vaccines prevent hospitalization and death. And we also know that the adenoviral vector vaccines, that's the Oxford AstraZeneca one and the Janssen vaccine, build immunity with a longer interval between doses. That's been known for some time. So armed with this knowledge and the data from the trials that were being done, the NHS vaccine deployment decisions were made by the Joint Committee on Vaccination and Immunisation. This is a scientific committee independent from government, not by politicians. And they looked at the data in December and saw what was going and predicted what they needed to do. And that was, first of all, give vaccine first to the people at most risk of death, the 99% of people with preventable mortality. So the older people, people over 50 and at-risk groups. And they also saw that extending the time between doses would allow us to immunize more people quicker to take the pressure off the NHS and the hospitals, and that the science from the trials was saying that this was not only a safe thing to do, but might be a better thing to do. There was a lot of argument about it. It was not controversial to those people who had seen the data at the time. Clearly, public confidence is really important. People need to be sure that new vaccines and medicines are safe. The regulator, the MHRA, is our global experts in medicines regulation. Before Brexit, we did this, the UK did this for the whole of Europe. And it was a huge disappointment that politicians and scientists were making statements across the world without understanding the data or process. Not in the UK, this was all noise from abroad. And from the UK perspective, most of the public have accepted the vaccines to protect themselves and others, as people do every year for flu. And even the recent rare side effects haven't really impacted public confidence. And that's because the media is being incredibly responsible in reporting, and people have seen the programme proceeding successfully and are confident that they're doing the right thing, having the vaccine. Clearly, the media focusing on hesitancy can make that low-level anxiety worse, and Eamon's going to talk about that a bit later on. And we've still got this very big concern about some communities Black and Asian minority particularly, of anxieties and hesitancy driven by social media and misinformation. Some things might backfire. So we think it's going to possibly be unhelpful to have a vaccine passport within the UK. That would be discriminatory because not everybody's been able to have a vaccine yet. It might be something that we do later on when everybody's had a chance to have a vaccine. Then you could start having, well, okay, we're going to use a bit of a carrot and stick to get people to have vaccine if they haven't done yet. But for foreign travel, it does look like we're going to need to prove evidence of vaccine or negative infections. What about the real world data? We've seen in the news over the last few weeks data from Israel, Scotland, Public Health England, but there's 3 studies that are really worth focusing on. One was the Bristol Avon Cup study that's a preprint that was made public on the 3rd of March. And this study looked at people over the age of 85 who'd been admitted with COVID to Bristol hospitals. And they showed that the Pfizer and Oxford AstraZeneca effectiveness at stopping old people over the age of 85 coming into hospital with coronavirus or dying was 80% for both vaccines, identical. As I explained to you, those headline trials couldn't be compared. The real world data shows that they're both working almost identically. And that was just after 1 dose. That's astounding. We never see vaccines that good in people that old. And in this week, we've seen 2 other really, really great pieces of data. One is the Public Health England Siren study that looked at healthcare workers across the country, median age 46 years. And this study showed that Pfizer vaccine can, and which is the one that was given to healthcare professionals, can prevent both symptomatic and asymptomatic infection in working age adults against the Kent variant. So not only do we know that the AstraZeneca vaccine can prevent transmission, but this is good data that the Pfizer vaccine can as well. And this morning, and Jonathan Van Tam talked about this on the evening briefing today, the Public Health England showed a data set that shows that 3 weeks after receiving 1 dose of Pfizer or AstraZeneca, people are 40 to 50% less likely to pass that virus on to household contacts than if you haven't received a vaccine. And that is on top of a reduction of 60 to 65% of a vaccinated person developing any symptomatic infection in the first place, 4 weeks, 1 dose, 4 weeks after 1 dose of the vaccine. So not only do the vaccines stop you going into hospital and dying and going to intensive care, but we're now seeing evidence that that both of the vaccines we're using at the moment stop asymptomatic transmission in the community, which is just fantastic news. Clearly, people are worrying about the real world side effects. I'm not going to concentrate on these. This is extremely rare blood clots seen with AstraZeneca and now the Janssen vaccines when deployed to millions of people. And we don't yet understand the mechanism properly. It might be to do with the vaccine type or antibodies or something else. But we've got brilliant surveillance for all new medicines and vaccines. That's how this very rare side effect was found. And we will keep an eye on all the vaccines, not just the 2 that are on the slide. And I'm not going to go through this data, but you can see and find that really nice public communication of risk and evidence communication that, again, was used on the national briefings, showing just how rare these side effects are. And just if you look at the right-hand side, you can see the older population here in these bars. So this is the low COVID risk at the top, medium COVID risk, and like January when there was loads of COVID. And you can see that the benefit of the vaccine is really good for people over the age of 30, regardless of how much coronavirus there is. This is the AstraZeneca vaccine. But just here, where there's a low COVID exposure risk, in the younger age group under 30, the risk of severe COVID versus the risk of going to ITU, the risk of severe COVID going to ITU and the risk of a potential harm of the vaccine is about the same. So whereas the MHRA have said, you know, we can use the vaccine, the side effects are rare, because we've got Pfizer and Moderna and other vaccines, the JCVI, the committee that advise, have said that for people under 30, we'll use a different vaccine than the AstraZeneca one. But if we went back to another wave and we didn't have any Pfizer vaccine left, we could use the AstraZeneca vaccine as before. So what do we need to do now? We've still got new trials. We're starting the Valneva trial next week in Southampton. This is the whole viral vaccine that might provide some protection against mutations, because it's not just against spike, and a Medicago trial. That's another company different technology. We've got to look after all our trial participants as we deploy to the NHS. We've got to think about vaccine passports for them if they're deployed for other people. And we've got to look long term at how long the immunity is lasting. And we're doing 3 trials to inform policy next year. The COMCOV study and COMCOV2, led by Oxford, is using one vaccine and then another in different schedules and different times between them. That's not just important if we run out of one vaccine or the other in the UK in the summer, but important globally. And CEPI, the International WHO committee that's delivering vaccines to the world, is funding part of that study. And we're also doing a study led in Bristol, looking at whether you can give flu and COVID vaccines, one in each arm at the same time, because that could be important if we need a booster in the autumn. We in Southampton are leading the Cough Boost study, where we're going to study the potential boosters that might be used in the autumn. And we're going to start that study in June, recruiting about 600 people in Wessex across Portsmouth, Southampton and Bournemouth, but we're going to open 18 sites across the country to study those boosters, and University Hospital Southampton is leading that study for the country. And we're also looking at children, pregnancy and people with other conditions. The Octave study led out of Birmingham is studying people in an NHS programme who've got underlying health conditions. Pregnancy studies for Janssen and AstraZeneca have had to be put on pause while we understand more about the side effects. The Pfizer pregnancy study is going to start soon, and the PregCov study, which is another nationally run study, is going to be looking at also at all the vaccines available with people who are pregnant. For children, it's more complicated. The Pfizer studies submitted data for the teenagers in the States. Then that hasn't yet come to the UK for submission and looking at by the MHRA. But the 2 studies, the AstraZeneca and the Janssen studies, have had to pause while we find out more about the side effects. Does it matter? I don't think so, because even as a pediatric infection person, I would want to be sure that we should be of the safety and the dose, and that we need to immunise children before we go ahead and do so. Children don't get severe COVID-19 disease. Even the incidence of long COVID is not thought to be that high, although it does occur in some children. And it might be that we have to deploy vaccine to keep the schools open in teenagers, but actually with the transmission levels being driven down now and immunising adults, it's unlikely that we're going to deploy vaccines to children for individual protection. And we would only really do it if we've got enough vaccine available once we've done adults and boosters, but also if there were a new mutation that was spreading wildly and it was thought that we needed to immunise children to protect society. But it's not, my best guess would be late 2022, perhaps earlier, but maybe after. Finally, live viral challenge trials you might have heard of, led partly by Southampton. There's a national consortium going on in Oxford and Imperial, but Rob Reed in Southampton's very involved in this. This is about setting up an experiment where people volunteer to get COVID, but they can be given vaccines beforehand, new vaccines and new technologies to accelerate the vaccine development. And we in Southampton did the detailed public involvement work to demonstrate public acceptability. People want to take part in these studies, and when the ethics committee approves the protocols, then they can take place. So in summary, the key issues for the NHS this autumn are: will a 3rd dose booster be required? Which vaccines will we use? Do we need Wuhan's, the original strain or variant strain vaccines? Is it all ages or just people in the older age groups or over 50? Can we give flu vaccine at the same time? Critical for our GP colleagues who are delivering the vaccine programme, and James is going to follow me. If we can give flu and COVID on the same day, that's a huge benefit for the system. And we need to know about transmission more going forward, not just for teenagers and children, but for adults as well. So thank you for listening. We've clearly got an ongoing need for clinical trials of different vaccines and technologies to optimise everybody's protection, address the issues caused by mutations. We need a manufacturing supply chain globally, because the best way to stop the pandemic is to ensure vaccine supply to the entire world, not just the UK and Western countries. And somehow we've got to avoid vaccine nationalism and help that to happen. I'm going to hand straight on to James now, because we're tight for time this evening. And James Allen is our chief pharmacist. He's going to tell us about the deployment of the vaccine at the hospital here in Southampton.
Thank you very much, sir. And good evening, Sol has said, I'm James Allen, I'm the Chief Pharmacist at UHS, and I've been the programme lead for our COVID vaccination programme. I've been asked to cover some of the practical aspects of the UHS programme, and Sol has covered a little bit around some of the unknowns. And I suppose one of the things to hold in your mind is that the programme has been having to adapt and incorporate as the new knowledge and new information comes out. And that's one of the things that we've had to do over the time. Next slide, please. So, and next slide again, please. So a brief summary of our programme so far. To date, since beginning at the end of December, we've managed to give just over 37,000 doses of vaccine through our hospital hub. And of those, but basically the majority were Pfizer vaccine, so 36,000 of those are the Pfizer vaccine, and a small number of the AstraZeneca vaccine. So as hospital hubs came online across the country as the first places to start the vaccination programme, they were primarily provided with the infrastructure and the information around managing the Pfizer vaccine, because it's got its challenging storage characteristics, which I'll come on to later. By the end of our programme, we will have vaccinated just over 20,000 people in the local population, mostly healthcare workers and social care workers. And of that, around about 1,000 patients have been vaccinated in our programme, but that isn't our primary focus as a hospital hub in the way that NHS England has set them up. We're really also very pleased to make sure as a hospital that nobody is left behind in the programme, and that those have been essentially awaiting a specialist advice around vaccination in things like allergy are coming through a new allergy service that we've set up, and we've reviewed and vaccinated around 250 patients so far through that service. Next slide, please. So you will undoubtedly have heard that the Pfizer vaccine in particular is fairly tricky to handle. It's got some very specific storage and expiry characteristics, and that pretty much sets the whole backdrop to the programme. So here you can see a picture of one of our trained, experienced pharmacy technicians taking the Pfizer vaccine out of the dry ice storage that it comes in. So a quick summary, because as a pharmacist I couldn't neglect some of these characteristics. The Pfizer vaccine is shipped in containers that hold it at -90 degrees. And then once thawed, it cannot be refrozen or moved in large distances, and expires within 5 days. So that's pretty much the challenge all of the vaccine hubs face. And the most challenging bit for us as a hospital was not handling the ultra cold frozen vaccine to some extent. We do trials all the time that require those sorts of temperatures. It was the main concern was avoiding vaccine wastage, with that 5-day expiry to use over 1,100 doses of vaccine at a time. The AstraZeneca vaccine is a bit more practical. That vaccine can be stored in a regular fridge temperature, and when it was deployed, it was one of the main vaccines that was used throughout the country to use roving models, to visit care homes and to vaccinate people in their homes. And then finally, as Sol mentioned, the Moderna vaccine, in terms of the 3 vaccines that are available at the moment in the UK, has come online, and that's a bit of a middle ground so far, and is shipped and stored frozen, but once thawed and refrigerated, it can be used for up to 30 days. And that's not widely used across the country at the moment, although you could see the practical benefits of that coming to fruition. So far, as a trust, we've handled and managed around 6,000 Pfizer vials, and are really pleased that the sort of processes we've put in place and the expertise we've got has meant that we've only really had to lose 14 vials because of preparation error, or because they were dropped or handled incorrectly. This is in part because of those systems, but also because we've used skilled pharmacy technicians to help with the making and the preparing of the medication. Next slide, please. So with that backdrop, what were we asked to do? So we as a hospital hub were asked to focus our vaccination efforts on health and social care workers. For UHS, this meant that we were involved in vaccinating everyone across Hampshire and Isle of Wight in terms of health and social care. That included nearly 13,000 staff at UHS, but also other organisations such as South Central Ambulance, Hampshire Adult Services, private providers, dentists and community pharmacy, you name it, we were involved really. We had to contact these people and organise them and book them in sufficient numbers to avoid that sort of those numbers we talked about earlier in terms of the 1,100 doses. It was really important, and Sol mentioned it in his talk, about making sure that we give vaccine to those at risk first. So we did a two-phase prioritisation in the organisation, where we used occupational health information to make sure those that were at the highest risk of coming to harm from COVID, because of assessments that had been made, were vaccinated really early in the programme. And we almost tried to do those guys as separately as possible, because the last thing we really wanted was to be vaccinating those individuals in a line of people that had potentially been working on the front line with COVID, remembering we started this programme right while we were in the thick of seeing lots of COVID admissions. So we tried to make sure they were separated, and also tried to be cognizant that they may very well, having been shielding for quite some time, have a level of anxiety about visiting the hospital at the time that we were doing it. We also needed to be consistent about the legal mechanism we used for administration, and we chose a prescriber model because that would be adaptable and consistent. So using our expert prescribers, initially consultants that had offered their time and pharmacists, but more recently some of our retired consultants have come back to support the programme. The beauty of this was that we weren't constrained in any way by any of the national documentation, and we could be really reactive to any changes in guidance, advice that was needed at any one time. And then finally, really in terms of organisation and process, the real key thing for our system was our IT system. The national booking system wasn't available when we went live, so we had to build from scratch our own booking and scheduling system. And our colleagues in IT here have been absolutely fantastic in building a really flexible and useful system. One of the things we omitted at the start, but we really needed, was a self-booking process. But once we got that on the go and everyone was using the self-book process, we were vaccinating just over 700 people a day at the height of our programme. The administrative burden of the whole programme was something that perhaps we underestimated, and we know that at the start we had to submit quite a lot of data into the national system. But if I had my time again, we'd almost certainly be looking to put more time and effort into thinking about the administrative burden. And it was tricky at the start, I must admit, but we vaccinated just over 80% of our workforce at UHS in just over 2.5 weeks. And I really think that made a big difference to both morale and also how we managed to proceed during COVID. We're now at a state where we've vaccinated over 90% of our clinical workforce. Next slide, please. And I think right from the start of the programme, we were really keen to use the skills of people for what they were comfortable to deliver. And so that meant that we used, instead of training a new workforce like they had to do in primary care, we were fortunate enough to use people's offers of support, but also to use them in roles that they were comfortable with, which meant they brought their own skills, their own expertise, and that they could look and help us refine the programme. This really meant that we could refine it quite quickly. People were providing guidance and changes and suggestions all the time, and then we could scale the programme at pace because people were very comfortable with the roles they were working with, and that we weren't having to necessarily provide a great deal of oversight because it's what they did in their day jobs. I'm a real firm believer that one of the successes of the programme was in highlighting to me and to others how everyone in NHS provides a critical role. And this was really evidenced in the programme. So alongside doctors and nurses and pharmacists that you kind of partly expect to be in the programme, we really relied heavily on IT, HR, estates, procurement, finance, admin, security. Our communications team kept everyone up to date. It was a real team effort, and using these individuals' expertise really contributed to our success. Next slide, please. So next steps for the hub. We will be continuing our second dose phase programme, so we've got a few more second doses to finish off. We're supporting some of the other local hubs because we've still got the Pfizer vaccine available in our hospital hub, and we will be looking to refine and support the regional efforts in vaccinating those people that have got particular clinical queries or questions, and also those patients and public that have been waiting because there's concerns around allergy. We'll also be developing our booster programme, and it's going to be really important that we know those answers to the questions that Sol had talked about in terms of whether we can give flu at the same time and what the booster looks like. And I think we'll be taking a lot of the learning of the programme we've had into that booster campaign. And then we're also playing a big role, as you can see from the slide, in vaccinating some slightly more unusual venues, but we've been supporting the crew vaccination programme to ensure that we can essentially, so the port is as safe as it possibly can be. So we'll be doing that, and that will persist into autumn most likely. So I'll be around for questions, and I believe there'll be time at the end for those. But for now, I'll hand over to consultant cardiothoracic surgeon Ayman Al-Zatani, who's going to talk about myth busting and increasing vaccine uptake in our communities.
Thank you very much, James. Can we have the first slide, please? Okay, thank you very much, James. The talk I wanted to make, to put to you today is to do with what's the communities like, and that vaccine hesitancy that's been talked about in the media. And as a UHS employee, and I can see different people from different backgrounds, I can see some communities are more hesitant than others, and there are a variety of factors: socioeconomical, cultural, racial. But you can remember from last year, the first wave of people, in particular healthcare workers, who have fallen, to COVID, have been from the ethnic communities. Hence, when it comes to the vaccine, sadly enough, these communities were some of those who have been resistant or hesitant to say, and I think there was a variety of factors related to that, for the disease awareness first of all, and then the vaccine to follow up. And there's been a lot of effort there to look into this, but and I think some of the facts to me came through looking at, next slide please. So when we were, in the UHS, we were redeployed to help with the COVID effort. I found myself on proning shifts, working with two gentlemen from Eastleigh Fire Station Finest, who were volunteering their services to help turn patients in ITU, because the staff in ITU were really run off their feet, trying to sort of look after patients directly. So the physical act of turning was something which did not require a specialist nurse, but maybe a specialist consultant like myself. But being in those in ITU, watching the community, the various people and patients there, and a lot of them were from the ethnic communities, made me more concerned about the uptake of vaccine and the uptake of the advice in general about social distancing, face mask, and crowding. And that's why I, with others, next slide please. We started looking at sort of how can we get the message across to the people in the communities about that this vaccine is safe, it should be worthwhile. I first went to my colleagues in, I've trained myself to be a vaccinator, and I took part in some of the vaccine effort in the hub in the hospital. And then I asked my colleagues who are from the variety of backgrounds, in addition to myself getting the vaccine, my first and second doses, I asked my colleagues to get some pictures of them so that we can show the community at large that this is a vaccine taken by people from ethnic communities working in the health sector. Seeing is believing, and I think a lot of the unfortunate misinformation which has been traveling around social media, in particularly, with a lot of misinformation and disinformation, if I want to call it, has been propagated and it's like wildfire. So you had to use something which can be close to our community's mind. When they see people from the healthcare sector, people like them having the vaccine and people like them talking to them, then that's the best cure for this misinformation. Next slide, please. So one of the first thing is that we reached out to some of the communities, and we managed to, in particular in this one in Medina Mosque, which is in the center of Southampton, we've actually approached the Imam, who's been very proactive and said, look, we want to talk to the community directly. So they gave us a link so we can speak before their Friday sermon to them and make them aware of the vaccine, and get them interested in it. And one of the problems we've had is that the trust as well, which meant that to break that kind of misperception of is that we've had one of the 31st community-based vaccination in the mosque itself, and we've run 2 in the mosque and 2 in this mosque, Medina, and 1 in another mosque in Northern. So Medina Mosque, for those who are aware of Southampton, it's in the it's in the one with the green dome, and we managed to get sign up for 100 people to sign up straight away after the sermon, and we've managed to have the first successful sort of session on Friday afternoon on the 23rd of March, and we've managed to do 100. Then we've done another session for 100, and then after that, a week after that, and a week after that, we've done 1 in Northern of 100. Next one, please. Now, again, you can see here how other ways of communicating the information and dispelling misinformation, or we use the local community radio. In this case, it was Ours FM, and I had Prof. Saul Faust with me and Prof. Anup Chauhan from Portsmouth. Again, having that confidence of showing that we as people from the various ethnic communities support this, and answering questions, dispelling myths directly, and taking questions from the public, again, to pave out the way for rolling out the vaccine. Next, please. Also, we use the social platforms which the community themselves use. So there is a lot of public media there, but you need to also tap into the local resources. In this case, we went into the Facebook of a variety of places, starting this one for Bashir Ahmed Mosque, where we've put a video there about myth busting for COVID and encouraging vaccine. So again, utilizing every avenue possible to reach out to directly the community from places they trust, and to counteract what's the misinformation out there. Next, please. Doing that as well through the Southampton City Council, who commissioned some videos in multiple languages. This one is in Arabic. Next, please. And then taking some pictures and putting them on social media related to those centers, so that again the community can see that it is within their centers and there are people from like them who are having the vaccine. Next, please. Last slide, I think. And here's some pictures again where people from the community were willing to have pictures done while they're having their vaccines in the mosques, in the gurdwaras. We chose a variety of people from different faith, again, to get the message across that the vaccine is safe, it's going to protect you, protect your family, protect your community, and hopefully that will have a ripple effect across the city. Thank you very much. And I'll hand over to Matthew, I think, who's coming over to me to speak to you about pregnancy and vaccination.
Okay, hopefully you can see my slides. Good evening, everybody. Thank you for the kind invitation. So just a few last thoughts and slides on COVID vaccination and pregnancy. I'm a consultant in obstetrics and I'm a consultant in medicine, and I look after women with complex medical backgrounds, and in particular the question of COVID vaccination has come up frequently in the last year, so I have some experience about some of the conversations and details of this. So just last week, the recommendation from the joint colleges, obstetricians and gynecologists, and the Royal College of Midwives, and the JCVI, the vaccine group, have moved on and recommended COVID vaccination in line with the normal age and health risks in pregnancy. And I noticed that there was a question in the QAs about the evidence supporting this. And at the moment, and somewhat embarrassingly, this is all indirect evidence. America and a few other countries went ahead and recommended and gave vaccine to pregnant women, and at the current time, when I last looked, over 90,000 women have had the vaccine with no safety concerns, either from immediate reactions or from subsequent births and childhood reviews. Nearly all of these were messenger RNA vaccines, so the Pfizer and the Moderna vaccines, and as suggested, there were no concerns seen so far. All of the speakers have already mentioned that we're in a difficult situation in terms of data, and there's much more data required about the COVID vaccination in general, and specifically about the details of how pregnant women respond to the vaccine. Are their antibodies the same as outside of pregnancy? How much protection does it give in pregnancy? What about the transmission? Women who are obviously at significant risk because they're typically got other young children at home, how will it influence transmission? So much more data required to help guide us. Having said that, at the moment, both the theoretical and the background experience strongly suggest that there's no significant concerns. So the UCOS, which is the UK obstetric surveillance system, has been carefully collecting numbers of women who've been pregnant with COVID infection, and they published these details just again in the last few weeks. In the last year, we've had about 7,000 admissions with women who are pregnant with COVID, who are COVID positive, which represents about 1% of the pregnant population. And about half of these women had symptoms, with a tendency for those admissions to be in older women, larger women, and some ethnic grouping, as previously mentioned. Typically, women were admitted at the end of pregnancy, and of those admitted and those with symptoms, about 15% needed oxygen, about 10% went to ITU, and of those with significant disease, about 20% led on to early birth, with about 20% admitted to special care of the babies. This is observational and quite subjective data, given the anxiety for the admitting team when somebody comes in with COVID symptoms and who's pregnant. And the ITU admission data is, I think, needs to be carefully judged in light of the fact that women who are pregnant and with COVID are more likely to be admitted to ITU. The larger, older women are more likely to be admitted to the hospital. They're more likely to be admitted to ITU. So it's a high-level snapshot, and has been useful for us to think about these type of numbers. But as previously suggested, more careful data is required. And then lastly, and unfortunately, there have been a number of relatively few deaths for women from nasty COVID infection, and the death rate seems to be slightly higher than the matched population of women, age-matched population of women who are not pregnant at the same time. So if you do get COVID infection, and if you do have it and it's difficult, then the risk of death seems to be slightly higher than the background age-matched population. This is I would recommend this site, which is the Winton Centre for Risk and Evidence Communication, and they, as Professor Faust showed on one of his slides, this nicely illustrates the balance of risk for the AstraZeneca COVID vaccine, which is not going to be the vaccine that we recommend in pregnancy. And this is the approximate rate at the current time throughout the country, with the increasing ages down the middle of the slide. And as you can see, if you were to vaccinate 100,000 people with the AstraZeneca vaccine, given the slight and recent concerns about specific blood clots, in the young age group, you can see that the risk of a blood clot is approximately related to the benefits in terms of ITU admissions prevented. So this doesn't talk about the benefits of preventing transmission. This is just a personal benefit. But as your age goes up into the typical groups that are not pregnant, the benefits of the vaccine far outweigh the very unlikely and low risk of a specific blood clot. So this is linked. These numbers are really importantly linked to the background rate of infection and linked to the AstraZeneca vaccine. And there are other graphs there which talk about the what happens if this rate goes up, and these numbers change quite dramatically. But it's a useful balance for showing people what are the benefits versus what are the risks in a simple table. And I'd recommend the Winton Centre for further illustration of those of the benefits and the risks. So the combined colleges has done lots of work, and again this is a snapshot of just the top of the really useful information sheet which has been published and updated recently. And the recommendation from the national group is that the details of the recommendation is that they recommend that we offer women the COVID vaccination as determined by their background, age and other risks. And so it's an offer of COVID vaccination. So it's slightly unusual wording when we recommend vaccination quite clearly for other infections in pregnancy. And the information sheet, again, I can leave you to look at the detail. It's very useful. It covers a number of really pertinent questions, helping to guide those decisions for pregnancy. So a few unusual last features. As I've mentioned, vaccination is already part of normal antenatal care and is strongly supported by a highly robust level of evidence. And pertussis and flu are part of the normal vaccination in pregnancy, and they protect mothers and babies. There are some concerns about the vaccine and its relationship to conception and fertility. And whenever I think about this, I think about toilet rolls, which was, as you all remember, were one of the human factors, the human behaviours that we noticed right at the beginning of the epidemic. There's absolutely no evidence that the vaccine is related to any kind of change in conception, any change in fertility, and women should be reassured that they don't need to avoid pregnancy after vaccination and that COVID does not affect fertility. But the toilet rolls is to remind me and to remind you that people make decisions with their hearts and their human factors as much as they make decisions with their brains, if not more so. And then lastly, the risk with the AstraZeneca thrombosis concern is, as Saul suggested, it's a very unusual, exceptionally rare reaction to an inflammatory process provoked by the vaccine. The risks are really tiny, and importantly, it's not related to the prothrombotic conditions in pregnancy. So my last slide. We should be offering and recommending COVID vaccination in pregnancy as we should be outside of pregnancy. The benefits are great and the risks are small. This should occur in the usual way of discussion and making shared decisions, as always. Vaccine hesitancy is being covered, but there's clearly a range of hesitancy which can be discussed quite specifically, as depending on what the hesitancy is about. And then, as always, that we're all humans, that we all make human decisions. We're influenced by human factors, and to work that into our conversations and work as always. Thank you.
Okay, well, thank you. Thanks ever so much to Matthew and the rest of our presenters. We've had quite a few questions that have been coming in, and I think quite a lot of them actually have been dealt with in the chat. But we've still got a few minutes left to run. So if there's anybody who would like to ask any further questions, please do so. There's a couple that were submitted beforehand. One of them in particular was about the the length of time that the vaccines were likely to be effective. In other words, what was the likely the decay time of protection? And question that I'd like to turn that into a question for Saul. What really is known about that, Saul, and is there any conclusion that can be drawn from today's announcement about further orders of the Pfizer vaccine?
Not really. I don't think in relation to today's announcement, Peter. But I think this is where people do need to be patient. If you're going to find out how long the antibody lasts, then we have to study people who've received the vaccine and then follow them with blood tests. And that's what's happening to all the people who took part in the trials last year. So we're just starting to see the data this week that shows that people have got very good antibody levels after 6 months after the second dose of the Oxford AstraZeneca vaccine. It's not in the public domain yet, but we've been talking about that in the trial group today. And so some people, as the year goes on, will get further and further down the line and be able to know. But and all the trials are doing that. But the COV boost study that we're going to be doing is clearly it's not the ideal time, because it's going to be 3 months after the people have received a second dose. That's because we have to make decisions as a country about whether we're going to give a booster and protect everybody to be absolutely certain, or to protect groups at risk with absolute certainty over the winter. Because if we left it and actually found that we then did need a booster, we'd be playing catch up and it might be too late. So by this time next year, we'll have more information. But I think our sense is that there probably will be a booster for the highest risk people, maybe healthcare workers, maybe not. We just don't know that yet, in the autumn. And the hope is that it will be able to be given alongside a flu vaccine, and that will make the GPs and the vaccine deliverers, people like James's team, as I said, much easier and pragmatic to give. But if you think we're only just starting the under 40 to the 42s now, and then down, the younger people aren't going to need a booster this winter.
Okay, thanks, Saul. I've had the odd technical problem here, and it may be that I have missed the odd answer to questions, but one which was submitted beforehand, and I don't think it's been explicitly answered, and this essentially relates to the emergence of new strains overseas. Will vaccines cover new and dangerous variants, be able to get ahead of the game and be available in time for the vulnerable to be protected in advance? Will vaccine creators always be playing catch up while the population going back to square one with an effectively new disease in the meantime?
No, we're never going to go back to square one. There's a lot of scaremongering out there. That's never going to happen. And the hope is that we'll get to a stage where it'll be a bit like flu. We'll be well on top of the game and predicting and being able to make vaccines in advance. But we do understand a couple of things about the mutations. We know that to overcome the mutation, we either have to get the antibody level for the original variant high, or we might use a variant vaccine. You don't have to have the variant vaccine. And there's some scientific theories, but also borne out in experiments, that it can be the case that you use a variant vaccine as a booster and your immunity gets worse. So it's really important that we do the trials carefully and properly. But we know that all of the vaccines, if they when they produce the antibody levels that we're seeing in the trials, will protect hospitalization and death, even for the variants. So we know this from the Novavax vaccine and the Pfizer vaccines in South Africa. We know this from the AstraZeneca vaccine in Brazil, and we know this from Pfizer elsewhere, and the announcements this morning for Pfizer and AstraZeneca with the Kent variant in the UK, that if you protect people with and you get your antibodies high enough, you do protect against the current variants. So I think people can be reassured, actually, that we are going to be on top of the game. And that's why we might give a booster to get the antibody levels up really high this autumn to the most vulnerable in society.
Okay. Thanks very much, Saul. There are a couple of other questions, but I just wonder whether any of the presenters wanted to, because we've still got a few minutes left, whether any of the presenters wanted to add orally to have a little time to any of the written responses they made to questions during the discussion.
No, I would just say, Peter, a couple of people have submitted sort of quite personal questions in advance, which I don't think we should reply here. And maybe people could, if they want to, they can email us or contact any of the medical staff, or actually, if you've got concerns, talk to your GP and your hospital consultants, because they will, or your hospital consultant, because they're the best people to advise you about your individual circumstance.
Right. Amen.
Yes, what I would like to say, if anybody who's been attending today, please, you are the ambassadors into the community. Please, each one of you will be the ripple, it's the pebble in the pond. Yeah, when we did the 100 people in the mosque, we know that there are 20,000 people across the city, but each one of them have so many contacts. So you need to be the ones who are spreading the word. You shouldn't be waiting for the GP letter, because people should use those personal contacts to make get the word out there that we need to get people vaccinated. It's not for you as much for people around you, especially for the young community, the ones in extended families, because this is how we're going to sort of show a difference. And hopefully we've shown some, but we'd like to see a bit more, and we don't want to go back to what we were doing last year. Thank you.
Excellent, thanks. Matthew.
Thank you, Peter. I just wanted to pick up on the question of breastfeeding. All that I said about pregnancy includes the period of breastfeeding. We would strongly recommend the vaccine if you have additional risk factors and you haven't had it already, and if your age becomes apparent in the next few months, then please, we'd recommend the vaccine.
Thanks, Matthew. Okay, I can't see any more new questions coming up. We are about to time. So I should probably wrap up at this stage, and none of the presenters got anything particular they want to add. Whenever we've had members' evenings, which particularly those which were when they were live, one of the things I always used to say is that I am immensely privileged to be the chair of this wonderful trust, and I want to say that I've never felt that more than over the course of the last few months. UHS performance during the coronavirus epidemic has been quite extraordinary. You've heard from James the story about how we rolled out staff as quick as, how we rolled out vaccinations as quick as any trust in the country to our staff. It was an immensely professionally managed program. We had one of the lowest instances of transmission of COVID within the trust of any hospital in the country, and I am not aware of any trust which delivered more help outside area to other trusts. We took a total of 33 patients from places as far away as Birmingham, and as I said, I'm not aware of any other trust which did more. And I have to say that my pride in the organisation is only been enhanced this evening by hearing the incredible stories what our team has done, and hearing the authority of our staff. We really are extremely privileged in the UHS to have such a wonderful collection of highly talented people. So I'd like to thank the presenters on behalf of everybody. Also, we really want to have feedback on the event, and I think that Sam has going to be indicating how feedback can be made available, because events like this very much are for membership. We want to talk about the things which are of interest to members, so please do give us some feedback, and I hope very much that I shall meet very many of our members on evenings like this, but for real rather than on screen at some time in the not too distant future. So thanks to the home team for organising. Thank to you all for attending. Thank you to the presenters, and look forward to your feedback. Sam, is there anything that you would like to add?
I don't think so. No, I think yeah, you covered everything. I'd just say, please do leave your feedback so that we can know how to improve next time, and we'll be sending a post-event report covering questions and a live recording as well.
Good.
That's it.
Right. Thank you all for attending, and look forward to meeting you in inverted commas all again soon. Good night.